afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. And before starting this webinar, let me introduce the speaker for this session. He is none other than Dr. Rajesh Teli sir. And let me share some of the achievement of sir. Sir has done MD, consulting physician and non-interventional cardiologist at Ammunkar Hospital, Rajkot. And today he is going to discuss on a very important topic, that is case files in hypertension when stress management made the difference. So to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thanks for the nice introduction and good afternoon, everybody. Today, I'll be discussing some of the very important aspects of the management of hypertension. In current era, where we are having technology, we are having artificial intelligence for the help of our clinical knowledge, it is very important to understand that the basic history taking will be playing a very vital role in spite of having all the armamentarium of investigations and all the latest technology we apply. I personally believe that the treatment of hypertension is an art which not only requires a clinical judgment, but as a doctor, I always believe that we have to understand, apart from medical science, we have to understand the social science, the social aspect of it, and the spiritual science. If we combine all the three sciences together, then only we can give a proper justice to the patient's care in a proper scientific manner. So, I will be starting the discussion that, as all of us know, that the lifestyle and emotional stress are very important factors as a contributing factor for hypertension. And all of us know that stress can elevate blood pressure via sympathetic overactivity. This case highlights how managing stress led to improved outcomes. And many such cases in our day-to-day practice are falsely considered as resistant hypertension. Today, I will be discussing three different cases where we have utilized the latest aspect of the evaluation of the patient, and still the analysis of the technological aspect has helped us to manage the hypertension. So, I will start with the first case. Here is a gentleman who is a 45 years old male, a businessman, a very busy person. Almost you can say working in his business from morning till night. And he was diagnosed with hypertension 2 years ago. And in last 2 years, he had frequent headaches, fatigue, irritability, and he was being treated initially by all general practitioners, the family physician. Then he consulted 2 or 3 various physicians. And in spite of changing one doctor from another doctor, and remember, his compliance was very good. See, most of the time when a patient goes to a doctor with uncontrolled hypertension and showing you the prescription, our first concern is that whether he is taking proper medication or not. So when this patient came to me, I found that his blood pressure was 162 by 100 millimeter of mercury. He was overweight with BMI of 28. His lipid profile, blood sugar, creatinine were within normal limits. And his systemic examination, all other parameters, resting cardiogram, the sonography of kidney, the echocardiogram were all normal. And in past, he was treated by 2 different physicians in 2 years. So initial management with his prescription revealed was he was receiving perindopril 8 milligram. As per the prescription, it was started with 2, then 4 and 8 milligram, and indapamide 2.5 milligram. So when he came to me, he was on 8 milligram of perindopril and 2.5 milligram of indapamide. He was advised lifestyle modification. He was following reasonably good diet. He was exercising every day, and he had stopped smoking. And in spite of the above medication and lifestyle modification, BP was persistently above 160/100. And therefore, I felt that let me try to add one more drug so that initially I just wanted to take some time to evaluate the patient, to understand this patient, that what should be the next approach to control the hypertension of this patient. So I added 5 milligram amlodipine and asked him to come after 2 weeks with a regular BP checkup, either with his general practitioner or by home monitoring of blood pressure. So after another 2 weeks, again he came to me. I found that BP's overall was not satisfactory. I increased the dose of amlodipine to 10 milligram and again followed it up for another 2 weeks. So now here is a situation where a person is on optimum dose of S inhibitor, optimum dose of amlodipine along with indapamide, which also was titrated to 5 milligram. So here, after follow-up of 2 to 4 weeks, the patient was in a practically same situation. Now here I was in dilemma, as initially I mentioned that such patients are labeled as resistant hypertension. So I was thinking whether I should subject this patient for detailed workup to rule out secondary hypertension. And here, in most of my patients, I am utilizing ambulatory blood pressure monitoring, as I'm telling that the newer modalities which are coming to us, they help us a lot. So I subjected this patient to ambulatory blood pressure monitoring, and most of you are quite aware that the most important aspect of analyzing ambulatory blood pressure monitoring is to find out the nocturnal dip. If there is no nocturnal dip, there are high chances that we are dealing with secondary hypertension. But in his case, the analysis showed that there was good nocturnal dipping, and there were two striking findings in his analysis of ambulatory blood pressure monitoring. His blood pressure was high in the ambulatory blood pressure data around 11 a.m. and 8 p.m. It was very striking. So almost BP 170, 100, 11, and then remaining higher, higher. And then after about 2 hours, again touching to 150, 140, 90. And same story around 8 to 9 p.m. So this striking feature that why this gentleman is losing the control mainly during this time, I had to go into the detailed analysis of his history so as to find out what could have been the cause. So I took his detail and I started asking him that you tell me your daily schedule from the morning. So it was a schedule that he was going to his showroom at 11 a.m. and he was returning back at 8 p.m. So both the times he was self-driving. So at 11 a.m. in the hectic schedule, it was about 40 minutes run. So he was daily driving twice a day in the 11 a.m. time and 8 p.m. time, making his blood pressure uncontrolled. And in our city, 11 a.m. and 8 a.m. p.m. are peak hours as far as traffic is concerned. My dear friends, all of us know if you are driving self, whenever I am driving, we know the situation, what situation is there in a traffic, in such a busy schedule. And most of the professionals, doctors, such businessmen who are always occupied mentally, they pass through a very tough time. And so, as a part of treatment, I advise that gentlemen stop self driving and employ a driver. And he agreed to my suggestion. And surprisingly, after stopping self driving, his BP gradually started coming under control. And almost after 8 weeks, his blood pressure touched 130/80. And we repeated his ambulatory blood pressure monitoring after he had a driver, and the surge of blood pressure which was taking place was normalized, and it was so the patient was so much happy that even I could discontinue amlodipine because basically it was essential hypertension, so he was doing very well with perindoropil and indapamide. His 8 milligram perindoropil came down to 4 milligram. and indapamide to 2.5 milligram. So this case is suggesting that one can understand the amount of stress in our day-to-day life is playing vital role. And here we have latest technology of ambulatory blood pressure monitoring and correlation with history. So history taking, going into the detail of patient's day-to-day schedule, that is going to help us manage such case. So the gentleman is so happy, and he is regularly coming for follow-up, and he is doing reasonably well. So this is one case. Now we will go on to the second case. So his outcome after 8 weeks, his pressure was 132 by 80. He reported better sleep and mood, reduced frequency of headache, and he improved adherence to the lifestyle changes. So now we come to the next case. Again, I am emphasizing that the history taking and going into the patient's life, patient's social circumstances makes a very big difference. Here is a young female, 28 years old female. She came to me with history of repeated chest pain and hypertension detected by family doctor. I am quite senior, so usually those patients who come to me, they usually come after 2 to 3 previous consultation by various physicians. So she had consulted 2 physicians, and she was on propranolol 80 milligram and clonazepam palm 0.5 milligram BID. And every time she consulted a doctor, she was found to have tachycardia and hypertension. So most of our physician colleagues would rightly think that this young girl who is hypertensive has mostly anxiety-related hypertension, and they were quite right in prescribing propranolol and anxiolytic. They were quite right. And she was extensively investigated for secondary hypertension. She underwent renal color Doppler, his echocardiogram was done, her urinary VMA was done, her thyroid function tests were done. All the possible causes of secondary hypertension were ruled out. So we were practically, all the consultants were sure that this lady has hypertension only because of the anxiety. So now here comes the value of going into the personal history and the basic problem of the patient. I asked her in her personal history, she was married for 5 years and she was being investigated for primary sterility. See, now many times we think initially some of the doctors had only given her beta blocker anxiety and reassurance. Subsequently, some of the patient consultant had tried to go into the depth, but this patient was not fully confident of sharing her history. But somehow, I being senior, I investigated, I convinced her that she has to tell me her problems. So then she came out with the history that her husband was having azoospermia. Initially, she had come to me alone, so I said that you should come to me with your husband. I want to analyze and convince your husband about the problem which you are passing through. So during the when she came with her husband, her root cause was her sterility, and this was the stage when her husband was accompanying her. I explained to them that her chest pain, her hypertension is because of lack of child. Her treatment of hypertension is to have a baby in her lap. So initially the husband was little reluctant to discuss. But when I tried to convince him that if you really love your wife, the only solution, there are only two options, because he had practically 5 years, he had tried everything, but he had a zero sperm count. So I told them the best way is to adopt a child. That was, and I told her that she has come to me for the treatment of her chest pain and hypertension. The treatment is not medicine. Treatment is to have a baby in her lap. That is what we have to offer to her. So I discussed with the couple, but even the lady was not willing to go for adoption. So another option was to go for artificial insemination. Now, again, the husband was initially very rude, and I tried to convince her that, see, there is definitely, he was observing the condition of his wife every day, disinterested in life. Even her sexual relationship had worsened, and she had a lot of problem in her marital relationship. So I explained to her husband that the right way is either adoption or artificial insemination. And somehow her husband was convinced. They agreed for artificial insemination, and the couple went. Then I had practically no follow up of the patient, but almost after 10 or 11 months, the lady came with a box of sweet with a baby in her arm. See, the best part of practicing physician, a general practitioner, is to guide a patient with addressing the root cause. Not every patient of hypertension requires pharmacotherapy. So here we can understand that this young lady who was hypertensive has only problem of sterility, and the husband was not cooperating, and subsequently this lady has been accompanying her mother-in-law, father-in-law, who are my patients, and she is normotensive. So here again, second thing is that when such young females they come to us, of course, as per our scientific guideline, you have to rule out all the secondary causes of hypertension. But social history taking, analyzing the social circumstances, and find out the cause of stress, which is very important. And here is an example where this patient who had uncontrolled hypertension, uncontrolled symptom, could be managed with different direction. Her beta blockers were discontinued, no more anxiety, and she was cured of hypertension because this hypertension was purely stress induced hypertension. And therefore, this is another case where I think proper history taking, going into the detailed history of the patient is very important. So, in current situation where most of us are so busy, examining every day 30, 40, maybe more patients in a day, we have not enough time to go into the depth, and most of us are sticking to pharmacotherapy. I'm coming across many patients where all the junior boys, the physicians who are coming into practice, they just go on addressing the hypertension and simply increasing the dose, giving triple therapy, quadruple therapy, but not addressing the right issue. So at this stage, I personally believe that analyzing the social aspect and finding out the stress which is hidden in the mind of the patient is very important for control of hypertension. Now we will go to the third case. In fact, I have been practicing medicine for last 35 years, and I have so many number of patients where I have realized that only talking to the patient, only going into the day in and out activity of the patient gives you many solutions which pharmacotherapy doesn't give. Let us go to this case. Again, a 46-year male, an ardent social worker, day in and night. He was a known patient of essential hypertension, and he was on 4 drugs when he came to me: telmisartan, amlodipine, chlorthalidone, and metoprolol, all in upper level. And he had accompanied many needy patients, helping them and bringing them to me. So I know him personally for quite many years. I was aware that the kind of social work he was dedicated, he was almost working day in and out. So when he came to me and I examined him, I found that in spite of having 4 antihypertensive drugs, telmisartan, amlodipine, chlorthalidone, and metoprolol, he was on uncontrolled as far as hypertension is concerned. And he was so active in social service. He was almost working 12, I'm sorry, it's not 24, 12 to 14 hours a day. Practically, he would be running from this hospital to that institute, just giving his time for social work. And he had consulted many physicians and was receiving 4 drugs. And I thought that I have to analyze. Initially, I had in mind that I should have one more antihypertensive drug. Either I could have added centrally acting clonidipine, or I could have added alpha blocker, or I could have given him a diuretic, changing the chlorthalidone into the spironolactone. But the situation was that because I knew his lifestyle, I thought that let me go into the depth of his day to day activity and try to find out something, some factor which is existing. Because all these 4 medicines and all other physicians had already worked him up because of his social contacts. He knew so many doctors in our city and all had thoroughly investigated him. So, in this patient, instead of adding one more agent, I thought that let me go into the detail of his day to day life. So, I analyzed, I told him that you tell me the moment you get up in the morning and the moment you go to bed, you tell me your entire story. I want to know about your daily schedule. So, he usually gets up in the morning around 8:30 a.m. and he would finish his. He was not a very ardent, physically fit, but he was doing yoga. He was regularly doing yogasana and pranayam in the morning, and he would leave for the work around 10 a.m. So getting up around 8:30 a.m. and in half an hour to 1 hour pranayam, yogasana, and then his rest of the schedule, and he would start at 10 a.m. His meal times were not certain. He would say that I would take my lunch anytime between someday 2 p.m., someday 4 p.m., someday he used to skip meal. And he would return home around 9 p.m. and then he would take dinner and then he would spend time with mobile and was not sure when he would sleep. See, analyzing this activity, there are distinct suggestions that what could have been the factor which is not playing which is playing a big role in making his blood pressure uncontrolled. So now here we have to understand the importance of techno stress in our life. See, when I was undergraduate, I never heard of techno stress. All of us were not aware what is computer, what is internet, what is mobile life. But this era is an era of technology and the stress arising from techno stress. I instructed him that you should take his lunch around 1 p.m. And the advice which I gave that he should switch off his mobile at between 8 to 9 p.m. The moment he reaches home, he should switch off his mobile. That was the advice which I gave to him. And he was such a nice person. And he told me that, sir, the whole day I am just answering the phone calls, running here and there. So I have no time to surf internet, the social medias. So when I get time after my dinner, I usually surf the mobile. And let me tell you, friends, one of the most important reason of techno stress is use of mobile and use of mobile after 8 p.m. or after 9 p.m. See, we all are aware what is the sleep cycle and what is circadian rhythm. The nature has given a biological clock which regulates all our functions from sunrise to sunset. And this biological clock, all our uh, spiritual leaders, religious leaders, all our saints and rishis, they were all aware about this biological clock. And that is why all our rishis, saints, they would say you get up early in the morning, you do yoga, sun, physical fitness exercise, take early breakfast, take timely lunch, and go to bed. See, Jain Dharma preaches about chovya, early dinner. But the most important culprit I have found in my practice of last 5 to 10 years is the late evening use of mobile, because once you take mobile in your hand, you are into social media, there is no end. You don't know what is the full stop. And therefore, most of the patients who are using mobile after 8 p.m., after 9 p.m., they disturb their sleep cycle. The melatonin, which is released as a part of natural sleep induction, is suppressed. I can give you n number of examples of disturbed sleep patient because of use of mobile. And this is not limited to youngsters. I have many families where son or daughter-in-law complains about father-in-law that our father is using mobile till 1 p.m., 2 a.m., 1 a.m., 2 a.m. They don't know. So the late night use of mobile is suppressing our melatonin. It is inducing a poor quality of sleep. So even if the person sleeps who is exhausted with extensive surfing of the mobile, he doesn't get a good quality sleep, and that results into the early morning surge of stress hormone. So indirectly, the techno stress, the use of mobile, is pushing the patient not only to hypertension but hyperglycemia, even endothelial dysfunction, and uncontrolled sugar, and even sudden death. The sudden death and heart attacks, of course, we don't have any scientific data available, but there are high chances that in due course of time, we would come to know that these kind of techno stress is harming. So this patient religiously followed my advice. After 6 weeks, his BP remained under control, came down, and he is controlled only with telmisartan and chlorpheniramine. Subsequently, he has been doing well, his sleep has improved, and his involvement in the work, in a social work, has also improved. And that is what is all we have to understand the value. So, what are the key takeaways for current era of stress? Remember, friends, it is the most modifiable risk factor in hypertension. Why hypertension? All lifestyle diseases. If you focus on stress, find out the root cause. Not necessarily every person has got stress. See, driving may be hobby for someone, but those who are active, it may be a stress. So one man's food may be another man's poison. And again, I am really emphasizing that history taking is most important aspect of treating such patients. We have to give enough time. Many times I receive a patient who have already consulted another physician who are basically good physician. I ask them that why are you changing the doctor? The doctor who has been treating is very good. They say, sir, he's good, but he doesn't listen to us. He has no time to listen to us. So, in current era, to all our juniors, the family practitioners, the physicians, most important thing is to listen to the patient. Our teachers used to say that the diagnosis of the patient is hidden in his narration. And nowadays, holistic care is essential in chronic disease and management. And I always tell my patient that ahar, vihar, and vichar. You must regulate. Ahar means your diet. Vihar means you exercise daily, regularly, and control over your thoughts. Our Sanatan Sanskriti has taught us how to check our ahar, vihar, and vichar. So, in nutshell, hypertension is just one simple example, but to talk about hypertension, acid peptic disorders, diabetes, all other lifestyle related disorders can be managed by addressing the stress. And the stress can be very well addressed through our spiritual messages: control your ahar, vihar, and vichar. Thank you very much.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participant on their practice also. So we have received some questions from the audience. With all your permission, shall we take these questions one by one?
Yes, please. Yes, please.
Yes, sir. The first question I can say is from Dr. Subramaniam. He's asking,
Yes.
in your practice, how often do you identify stress as a major contributor to elevated BP? Could you please share some point on that, sir?
Sir, that is what I have narrated in three different cases. But believe me, those patients who have strong family history of hypertension, both parents being hypertension, where the environmental interaction, stress is a contributing factor. But if you find a patient who has no family history whatsoever, he has no other apparent stigma or risk factor for hypertension. You must consider it as a stress-induced hypertension unless proved otherwise. Because we all see what kind of lifestyle we are passing through. Most most of the stress are arising from our daily life, the attitude and the thought pattern of people, highly competition, very high competition, high ambition. Today the youngsters are so much about their career and ambition that they neglect their basic health. So I personally strongly believe that if you come across a patient who has no family history, no other apparent reason, go into the history taking thorough analysis of the lifestyle and you will find the solution.
Thank you so much, sir, for sharing your expertise on this question. I hope that Dr. Subramaniam has received his answer. So, one more question, sir. How do you differentiate between essential hypertension and stress-induced BP spikes in clinical settings, sir?
See, if you have heard the first case, see, stress-induced hypertension, indirectly when a patient comes to us for the first time, we have to label it as white coat hypertension. So, any patient who comes to us for the first time and is in a borderline or JNC stage 1 hypertension, it is always important not to start the pharmacotherapy. In previous days, what I used to do, I used to advise them that you remain in contact with your family doctor, check your blood pressure at different time. But now we have got a very important tool, that is ambulatory blood pressure monitoring. It's a very simple BP cuff attached to a small pager size BP machine, and for 24 hours, automated every 1 hourly, the blood pressure is measured and it is saved, and you get the data of every 1 hourly reading. So now the analysis of this ambulatory blood pressure monitoring is very helpful. And I think we physicians, all family doctors, should start utilizing this tool, because by using this investigation, we can differentiate. So if you analyze ambulatory blood pressure monitoring, most of the reading are during active hours, or when the BP is high, you can ask that at 2 p.m. what were you doing? So the correlation of activity and analysis of ambulatory blood pressure monitor will definitely tell you. See, if you find a pressure which is high during night time, even no nocturnal dip, then you must evaluate the patient thoroughly. Otherwise, you can keep them on lifestyle modification changes, stress management, and many of my patients I have been able to save them from pharmacotherapy.
Thank you so much, for answering all the questions, sir. I hope, sir, you have done justice to this topic, so I can't see any further questions, sir. As there is no more question, with all your permission, shall we conclude this session for today?
Yes, yes.
And sir, we would like to see you in future also with different topic. Till then, take care of yourself, sir. It was great
Definitely.
honor to have you, sir. Thank you
Thank
so
you.
much.